All right, thank you everyone for being here. Welcome, obviously. Thanks for coming to hear from our guest speaker, Professor Christina Pagel. Just to flag, this event is recorded, but only the screen and just sort of this side of it being recorded, so you're safe over there. Before I introduce Christina, I would like to acknowledge and pay respect to the traditional owners of the land on which we meet, the Gadigal people of the Eora Nation. It is upon their ancestral lands that the University of Sydney is built. And as we share our knowledge, teaching, learning, and research practices within the university, may we also pay respects to the knowledge embedded forever within the Aboriginal custodianship of country. So I'll keep it short and sweet. The digital health ECR community is excited to host Christina Pagel, Professor of Operational Research at University College, London. Christina's work applies mathematical tools, if I've got that right, and further across various leadership roles. Christina heads up research seeking to understand and communicate outcomes in congenital heart disease, research examining anonymized data to develop a better understanding of people's physiology changes during intensive care, and research aiming to improve services for children with complex health needs. So today, Christina is going to be speaking on the topic of the importance of failure, in an academic career, perspectives from for digital health specifically, in which she will draw on her experience in health and health data, including many key learnings from her involvement in the UK Independent Scientific Advisory Group for Emergencies, also called SAGE Group, and in order to reflect on career progression and how failure can lead to growth. Over to you, Christina. Thank you so much.
Well, thank you for inviting me and thank you for having me. Right, so I'm going to actually start off with a digital health example, which is from work I did almost 8 years ago now, when I spent a year in the US on a fellowship there, looking at a clinical decision support tool. And then I'm going to reflect on how I completely failed to learn from that project in a kind of a project that I did straight afterwards back in London. And then at the end, well, the second half is going to be more of a personal tour of my many academic failures. And because I think often when, especially early in your career, you look ahead at the people ahead of you and you think, oh my God, everything succeeded and I'm never going to get there. And that isn't what life is like, and it's certainly not what careers are like. And I think it's worth thinking about where things haven't worked quite so well, or whether we even talk about it as failure or not. So that's kind of what I'm going to cover today. So starting off with this. So this was a project. So basically, we know that implementing health information technology or digital health systems or whatever is actually quite difficult, right? And I would say it's much harder to implement them successfully than it is to develop them. Not least because the implementation is less exciting than the development, right? But so one of the things, what I was actually looking at was a clinical decision support tool that was meant to be by the bedside in intensive care, and it displays trends in real-time physiological data streams. So typically intensive care, you'll see people's heart rate, blood pressure, oxygen saturations and so on, but you only see snapshots right now. And what this does is it shows you the trends over the previous hours and days, and you can zoom in, and the idea was it would give clinicians a much better understanding of what was happening to that patient. And so in 2016-17, I looked at what were the barriers to implementation in 4 different hospitals that had all implemented exactly the same IT system in the previous 2 years. So I already knew that the barriers to implementation are well known, from time pressure, lack of buy-in, lack of engagement with other departments, workflow, motivation, the fact that there's a high perceived burden, lack of clarity around team roles, responsibilities. And I would say those are all barriers to using any digital improvements in healthcare. Already any improvements in healthcare doesn't have to be digital. And really what was interesting to me is that the system is great. Like the system is amazing, and it offered a step change on what was available before. But it's now been implemented in maybe 8 or 9 hospitals, including some in London, which is how I first came to know it. But no one was using it, right? There's only one hospital where people used it regularly, and that was the hospital in which it was developed. So how can a system be both really great but not helpful? And so what I did, which was completely new to me, I'm not a qualitative researcher, but I did semi-structured interviews with people over the 4 hospitals and the people who developed and sold the software, which included doctors and nurses, but also actually the hospital IT staff and people in the vendor company. And several themes emerged, which, well, none of them was about how good the technology was, right? Not a single one. That wasn't an issue. That was never the issue, right? It was contracting, engagement with IT, logistics, nurse and frontline engagement, and purpose, which I think is too often overlooked. And when I was thinking, okay, how do I summarize these? I decided to do it using cartoons, and I worked with a cartoonist to kind of try and extract the stories into a cartoon format. So I'm just going to show you a couple of them now. And the most important thing is that everyone there was an enthusiasm to improve care. That's how these things start. And so in this case, it was nearly always that one of the senior clinicians, and it was always actually a clinician, had seen this software either in another hospital, or they'd been to a conference, or they'd been talking to the vendor and said, this is amazing, I want this. And then they're like, fine, let's go ahead and get the contract. So the first big barrier was getting to contracts. So I'm not expecting you to kind of read through all of it, but it was basically that then you have this enthusiastic clinician who doesn't actually know the process of how you do these things, right? And so you have to go via leadership to get funding, finance department, legal department, IT department, governance department, procurement. And what you find is that at each stage, people don't know about the next stage until they get there, right? So there was no kind of forward planning. People weren't involved from the beginning, and it could take months, years in this case, and people getting increasingly frustrated. Then there are technical glitches. So however good a system is, however well you design it, there are going to be things that crop up that you cannot predict. And they are kind of obscure, right? And they're unique to each hospital. So these are just all real examples from different hospitals. So one was that they didn't have standard monitors, and so the display resolution was off. And then they had to fix that, right? But by changing, in that case, bespoke change to the code. Another one had a different system in the hospital upgrading their hardware, which made the whole kind of charting system go wrong. And then they had to take the new system offline for months. So they had started it and they took it off and put it back on again. Another one ended up needing a completely different security license to take up the system, and that took a while. So there are all these things that will add delays and frustration and difficulties that you can't predict. Logistics, I think, is really interesting because it's where, to me, like the project can fail or succeed, and people just ignore it. Like they don't think it's interesting. So this was meant to be a bedside monitor. And again, this was a common theme in all but one hospital, which did this really well. And they're kind of like, I just want to put my monitor up. And so, the teams are like, well, have you got the spec for the monitor? How big do you need to be? What resolution do you want? What kind of other equipment do you need? And for the clinician, this was an interesting question. They didn't know the answer either. And then he's like, well, I just want it by the bed. Okay, well, in an ICU, depending on the room size, there's actually not much room. There's a lot of other equipment. There are cables everywhere. There are weights on the booms. So there are all these kind of technical issues about where you can put things that medical staff aren't really aware of. And the teams that were implementing it were really frustrated that no one had talked to them about this before procuring the system. And what happened in a couple of places was that they ended up putting the monitor in the corner at the back, because that's where there was room. But that's completely, but then in daily life, right, no one looks that way, right? So it was completely wasted system. You've got this beautiful monitor that's right there, and no one was using it because it was just in the wrong place. And the nurses, were saying, no one asked me. Like, why would no one ask me where it should go if I'm meant to be the one using it? Nursing involvement in general was a big issue. And I don't know, maybe it's different in Australia, but certainly in both the UK and America, I would say the clinical profession is very hierarchical and much more hierarchical than academia. And I personally find it quite shocking at how little involvement nurses had or have. So these are just actual quotes from staff, from the clinicians, saying, we had a nursing contact, but we really didn't work with them that much. They weren't really involved until they wanted to tell the nurses to start using it. One of the clinicians was like, I think it's a physician tool. The nurses are going to be there, but I don't really expect them to use it. Whereas actually in an ICU, the person who spends most time by the bed is the nurse, right? Much more than the clinician. So if anyone should be looking at trends, you'd kind of think it would be the nurse. And then from the nurse's point of view, it kind of saying, oh, it's like, ta-da, we've got this new thing. Oh, that's the doctor's toy versus, okay, we're going to implement this, we're all going to own it. And so in her place, the nurses just didn't use the system, right? Because they didn't feel like they knew what for or why it was there. So in a sense, this was a quality improvement project, right? They wanted to improve outcomes. And the Institute for Healthcare Improvement has a model for improvement where you start off by saying, what are we trying to accomplish? How will we know if there is any kind of improvement? What changes can we make that will result in improvement? And they didn't really do any of those things in that hospital. There was, and none of the hospitals, none of them had any kind of way of measuring or capturing what difference that system made. And they didn't intend to either. And there was this assumption that you add this monitoring to the bedside and you'll end up with better patient care. And that was a black box. No one had ever articulated how that was going to happen. It was effectively that first thing where you have that clinician seeing the tool and going, I want that, because they think it will give them better patient care. And it was just never articulated. So that was kind of from that story. And so, I came away with that and said, oh God, okay, right. So next time I do this, I'm definitely ready to kind of think about how to implement better. Which is where I talk about the danger of enthusiastic amateur, which in this case was me. There was this, about a year later, there was a story about hats in operating theatres. And effectively what you have in a busy operating theatre is everyone in scrubs. You can't really tell who anyone is. And often you can have, especially in complex areas, 12, 13, 14 people in a room. And you want to be able to communicate effectively. And you don't want to just point and say you. You want to be able to use people's names. So the idea was, if you just have a name and their role, it should improve communication in the operating theatre. And some places have tried it and it seemed to work really well. And a consultant anaesthetist, where consultant is the highest grade in the UK in hospitals, came to me and said, I really want to try this. I'm in the theatre the whole time. I can see how we're not communicating well. I was like, this is brilliant. Love it. Let's do it. And so together, we're like, okay, well, let's design this. And so I thought, right, I'm going to measure it. I'm going to measure a baseline. Then we're going to measure what happens when they implement it, and so on. So, I designed a survey of how is with her on current levels of communication and patient care in the OR. We got results in her particular unit. What I think is quite interesting here is this is just for the questions, kind of, is it easy to speak up if you see a problem? Is it easy to ask questions? How's morale? And how often do you have delays because of communication breakdowns? And you can see there is a real hierarchy effect, right? Where for nurses, were much less confident in speaking up if there was a problem or asking questions, and also felt morale was much lower. Everybody actually admitted that their a majority said there were delays because of communication breakdown. So what happened? Well, you know, despite me saying, well, you know, we need to involve people from the beginning and think about the purpose and all the rest of it, there wasn't actually any real introduction. I didn't have any input into that side of it, but I didn't raise it as an issue either. And effectively what happened was it was sprung on people at a weekly morning meeting. We're doing hats next week. We're going to start with this new thing. And no real thought was given to the implementation. And it was because, looking back on it, like to me and her, it seemed like such an obviously good thing. Like we just couldn't see any drawbacks. Like it's not difficult, it's not risky. It's literally just writing a name on a hat, right? So what possible problems could there be with it? And so we just kind of forged ahead. So here's an example of how it was operated, but you can see straight away that because we hadn't thought about the implementation, we just kind of plastered something on our head, which could have fallen off, right? It's actually not a particularly great way of putting a name on a hat, and it doesn't look particularly professional. Here's another example where there's less patient safety concern. And one of the things that came out is, I don't know if it matters that this was designed or considered by me and her, we two women, but we just went for first names. Well, let's break down the hierarchy. Let's all be friends, you know. And in some ways that was good. So this was a WhatsApp I got from the consultant saying, this is Vic. She loves being called Vic, and she's been called Vicky for 8 years until one day when she had this on her head. So that's kind of a positive outcome. The hospital quality improvement team loved it. They tweeted about it. The nurses, it turns out, really loved it. Some of the new junior doctors loved it, but there was some real backlash. Some of the consultants absolutely hated it. And in fact, what was really difficult for my colleague was she lost her best friend over this. And it turned out that for some people, not everybody, but for some people, their role is a core part of their identity. And actually, they didn't want to be a first name. They're like, I'm the surgeon, or I'm the anaesthetist, or I'm so ever. The surgeons, typical surgeons, well, everyone knows who I am. I don't need to write my name on it, right? And they didn't really feel like they needed to know who the nurses were either. And they were like, well, I'm not doing it. It's stupid, right? And in hindsight, I was just so frustrated. I'm literally just on this project on all the importance and how you implement bringing people along, and I didn't do any of it. And it just neither occurred to us that there would be a negative reaction. And what we also found was that the hierarchies really mattered, and that the nurses loved it, but they could see the negative reaction from people who are higher up in hierarchy, and it meant that they were very reluctant to do it because of that. And as I said, you know, it definitely highlighted that the hierarchy mattered more than we had assumed it did. And the initial consultant who did it felt very jaded and burnt about it. And to me, I was there thinking, well, have I just made things worse? I've rushed in. I was a fool rushing in, basically. Now, there was some grounds for optimism. So what happened was that actually when they went to pay, you know, they thought about this again, and they made the hats nicer, where they printed on the roll and they printed on the name and people could choose their own designs. Then people started to say, actually, I quite like this. And so here was like another tweet from a few months later of someone saying, messaging my colleagues saying, thank you for coming up with the idea. The system worked brilliantly today, and we had more than 25 people in the room. So there are some grounds for optimism, but I think it could have been done so much better. And I still haven't learned, because I'm currently, as Adam said, I'm currently starting this big program of work around improving services for children with complex health needs. And you see such profound problems. I'm like, oh, great, we're going to do this. And realizing that I'm stepping into a field that has its own politics, its own history, and I'm new to it. And you can't just say, I know how, you know, I've got an idea, right? You just cannot do that. And I'm having to restrain myself because I'm somebody, I'm definitely, I'm an enthusiastic adopter of things. And I have to be very aware that that isn't how I can go in, right? It just puts people's backs up. So that's just that example. So now more about me and my failures. So the first thing I failed at was academia. I'd always wanted to be a physicist, like through my teenage years. And for various reasons, I decided the best way to be a physicist was to study mathematics. I still don't think it was wrong, by the way. But so I did an undergrad in mathematics, and then I went and I did a master's in quantum theory. And then I left. And I left because, as far as I could see, it was full of quite strange men. And I just didn't think it was for me. I remember going to finals exam with one of my fellow students called Ingo, and he turned around to me and he goes, "Don't you wish the exam was 6 hours long and we had no idea what was in it?" And I was like, no, why would I wish that? That's a crazy thing to wish. I want it to be questions that I've practiced for the last week. And I thought, well, if that's what it takes, if that's the kind of enthusiasm I need to have for this subject, then I'm not in the right place. And there were very few female academics in the department, and I just couldn't see it. So I left. Now, I did go back 2 years later. And basically it was kind of I was thinking about what I wanted to do, and I was considering doing like science journalism, and then I thought, but actually I want to be doing the science. And I decided I wanted to be an astronaut. And this was actually after, this will date me, but it was after Independence Day and Armageddon came out, and I was like, I want to do that, you know. And I spoke to the European Space Agency and said, what do I need to do? And they said, well, you know, if you can't fly a plane, which I can't, do a PhD in space physics, which I'd never really heard of, but I did. So I thought, great, I'll do that. And I wasn't expecting to enjoy it this time. I was expecting to go into a very male-dominated environment, which I did. I was the only girl on the program in the 3 years that were there, and I think I was the only girl for another 3 years after me. You know, it is quite heavily male-dominated. And then after my PhD, I went and I got a job in America. And I think what's quite interesting, and people talk about careers, is they very concentrate on the career side of it and how you make decisions and what's the right place for you and where do you want to be in 10 years' time, right? Now, I got a postdoc at Boston University doing space physics, great. But I went there because I was in love, and that's where my boyfriend was. And I think sometimes it doesn't help to pretend that your personal life doesn't have an influence on your career decisions. Like it should, like why not? Right. And I think trying to split that up or trying to make people feel bad because that's a consideration, just I can't see the benefit of it. And one of the issues with academia is that it is difficult. It can be difficult because you're expected to travel. And how does that fit in with your personal life and your personal happiness? And I'm a great advocate of saying, you know what, maybe it's not the best job for you, but if it's the best job for your life, then that matters. Anyway, I didn't become an astronaut, sadly. And I left space physics completely 3 years later. And that was all prompted because I had applied to get a fellowship on a spacecraft going to Saturn. And I didn't get it. And it really, you know, it wasn't that I was kind of cast down to the pits of despair, but I kind of thought, well, you know, am I actually any good at physics? And I decided the answer was no. I was good at mathematics, and I was good at, you know, I was good at a lot of the things around that I needed to do, but I was never going to be a brilliant physicist. And instead, I joined the clinical operational research unit at UCL, which is where I still am almost 20 years later, which is quite scary. And that was a much more deliberate choice where I really thought about, where do I want to be? What am I good at? What do I want to do with my life? And when I kind of was looking at using mathematics to support decisions in healthcare, it really spoke to me. And I thought, this is really interesting. And I really, you know, like the thing is with space physics, by the end, I was kind of studying electrons in interplanetary space, which is interesting. You get to go to really cool conferences and the science is interesting, but it didn't matter. Like, who gives a shit? It's like, it just didn't matter. And to me, it wasn't enough. Like, the intellectual excitement wasn't enough to compensate for that. I thought the only positive impact I'm having on society is that I pay taxes and I'm not in prison. You know, I felt like I wanted to do a bit more than that. So the other part of academic life, which is failure, is paper rejections, which happen a lot. And sometimes that's expected, particularly if you aim high for a journal. There's absolutely nothing wrong with that. But sometimes they can really hurt, and reviews can really hurt. And I've noticed it a lot with early career researchers who work with me, is that you can take it really personally and they get very upset. And you have to learn not to take it personally. And I found almost always you end up with a better paper, right? If you come out of a UC review and they haven't understood it, how dare they? Don't they see what I've undone? And go, well, okay, well, if they haven't understood it, whose fault is that? Right? Yeah, maybe they're reading it quickly. Maybe they're not really thinking about it. Maybe they haven't given it that much attention, but that's how people are going to read your paper, right? And it's your job to make it impossible for someone to misinterpret what you've done. And I think that's why, to me, like a bad review is almost better than the kind of rubber stamp, this is great, publish it, because it's actually not doing the job of improving your work. But the other thing is that sometimes you can give up on a paper. I've done it rarely, but I have done it. And sometimes that can be the okay choice. If actually you're kind of beating a dead horse and you can't quite face submitting it again, okay, well, who's it going to benefit? What is it you really want to get out there? And sometimes it's fine to walk away and move on to other opportunities. Grants, again, you know, depending on the grant, it can be a 5% success rate to 20% success rate. I mean, you're gonna lose more than you get. Even the best years of my academic life, maybe 50% hit rate, which is an amazing year. And they take so much work. And that, I think, is some of the most disheartening thing. And the problem with that is for grants, you learn more from the successes than you do from the failures, because you rarely get feedback, depending on what stage you're getting rejected at. And to me, the biggest place to learn for grants is to get yourself on a funding panel or as a reviewer, because that's where you see how other people talk about their research, and you learn very quickly which are the bits that matter. And how to explain why you're doing it. Often the why is the bit that isn't coming through. And you have to also understand that there is just some randomness, that if you're on a funding panel, you might get 20 research proposals that are all good. They're all fundable, and you've got money for 5. And then often it comes down to really pathetic things like, have we already funded someone in London? Okay, well, let's fund a different bit of the country. Or you have a panel chair who's got a particular interest in this topic, or you funded something on that 2 years ago, so now you want to do something else. So it's nothing to do with you. Sometimes it's just not the right time, but it can be quite hard to accept because they make a real difference. And so the biggest lesson from that, I think, is just is resilience. And the other one is there's no point putting in a hasty grant application. You're up against so much competition. If you're going to do it properly. I guess my other reflection on academia is imposter syndrome. I have it. It doesn't go away. Like, I always thought at some point you'll feel like you belong. Not the case. I still, all the time when I'm doing talks, particularly big ones, I'm there thinking, why is anyone listening to me? Which doesn't help that my mum's on the phone saying, why is anyone listening to you? But it doesn't go away. And I've come to kind of think of it, well, maybe it's a good thing, like maybe it actually makes you better. Because if you're trying out new things or new fields, or you're going into new ideas and new collaborations, you're always going to be a bit uncertain. You're always stepping out of your comfort zone a bit. So to me, it's a function of doing that. And actually, certainly for some of my colleagues, I wish more of them did have imposter syndrome. You know, like I'm not sure it's this terrible thing, but I think what people have to realize is that it does, like, you have to recognize it as that. You have to recognize, okay, at some point I have to accept that people are paying me for a reason and I actually can do my job, but you still have to think about, okay, well, what is it that I can get better at? And the other thing that I think people don't talk about enough is the uncertainty of seniority, which you will get to, and I think it's in any field, whether you stay in academia or do something completely different, this is an issue. And the issue is that you start off as something. So I started off, I wanted to be a physicist, and then I moved into maths for healthcare, and I was doing a lot of coding, a lot of mathematics, and I saw myself as a scientist and technical person and a geek, and And I really enjoyed doing that stuff. But then as you get more senior, then that's not your role anymore. My role now is often it's project management, it's recruitment, it's finding the funding, it's having the ideas, it's translating the ideas, it's working out what's interesting, who would be interested in this, how can I make an impact with it? And so I do very little of the technical stuff, but then you lose that identity. And sometimes I see early career research talks and I'm so jealous. And I wish I was doing that. And you have to kind of give up that side of yourself and cede it to the next generation. Because even if sometimes I feel like, well, I'd like to code, I'm like, well, I'm going to be much worse at it now than someone who's 25 and doing it all the time. And it can be quite unsettling, because then you're like, well, what am I? You know, is this really what I'm going to be doing for the next 20 years of my life? And I think it really it requires a complete rethink about what you want. And I'm still doing that. You know, I've been a professor now for 6 years, and you still, like, I still don't feel like I know exactly what I'm going to be doing over the next 20 years. All I know is that it's not going to be what I'm doing now. Like, I definitely want to keep feeling like things are changing. So I'm just going to go through what I now think about when I'm thinking about an academic project. I think, okay, well, firstly, is there a problem? And so often I always start by that. I need to care about the problem. And a lot of my work is where you can kind of see it in what I do, you know, like intensive care, disabled kids. I've been doing work on the Grenfell fire in the UK as well, COVID. So kind of thinking about, is there a problem? And then is someone already working on it? Do I think it's an important problem? Like, does it matter to me? Do I think it matters to society? And then you have to think, well, do I have something to contribute? You're like, maybe there are loads of people working on it who are much better at it than me, in which case you step aside and you think, okay, well, how can I support their work? Or maybe I should go and do something else. But I think it's really important that you always think about, are you the right person to be doing it? And there's a lot of academia, but also any job where it's word of mouth, right? I know a mate who does X and you come and talk to you. And you're really tempted to go, yeah, I'll do that because it's interesting. But then actually you're thinking, well, do I know anything about that? And I still fall into that trap a lot when I've started doing a project and thinking, well, I'm really not the right person to be doing this. Then you think about, who can I work with? Who is it that I think would be good? Who do I trust? Which is actually quite a big deal. Who's fun to work with? You know, I find you kind of end up with, I don't know if Jack found this, but you end up kind of with work spouses, where I meet someone, you really work together well, it's a lot of fun, you respect them, you have complementary skills, and then you just grab onto them, you apply for funding together, you stay together, like in that little work marriage. And then you think, who should be leading? And again, it shouldn't always be you. Often it shouldn't be you. Often you don't want to lead anyway, because it's a lot of hassle. And then you think about, how can I make that happen? And who are the relevant communities? So now in every project, we always involve people who are going to be affected by the changes that we're trying to investigate or research, whether that's the staff or patients or the general public. And how do you involve them in what you're going to do? And how do you create impact? So I think the biggest step for me as I kind of became more senior, and the reason I've started doing less technical stuff, is because it doesn't matter how good the technical stuff is if you can't get it into practice. And that is a people issue. It's a communication issue. It's thinking about the logistics, the practicalities, who do you need to get buy-in from? How are you going to pay for it? How are you going to do the politics? And I find that really interesting. But also, if I don't do that and it just sits in an academic paper somewhere, it doesn't satisfy me. So I guess the last slide now, I think as you go through your career, and again, I think this is true for any career, it's fine to be uncertain. It doesn't mean that you're in the wrong place. I think it's fine to question what you're doing and why you're doing it. It's okay to change your mind. I've changed what I've been doing several times, and I definitely think I have more changes in me. I think it's fine to try something new. I think if you choose not to do something new, that's fine too, but I think it should be a conscious decision. It's fine to fail. I think the other thing is to remember, and I think particularly this is an issue for women, is it's okay to succeed and not to talk yourself down, right? I think it can take a long time to work out what it is you actually enjoy doing, and what you're good at. I think those things can change. You don't have to love everything about your job to love your job, but you definitely won't. And I've seen people who keep changing jobs because they hate this one bit of it. It's like, there isn't this job where you love every bit of it, just doesn't exist. I think generally you need more of a reason to say no to something than you do to say yes. And I see this a lot. And again, I would say, particularly with women, that people say no because they feel like they don't tick every box, they don't have the expertise. And actually, a lot of it is about the intention that you approach something with it. And I think if you know that you have the right intentions, you should say yes. And finally, if you want to create impact, it needs a village, and you need to have a team. You need to think about who you need to talk to and involve. And you need to really have an articulated purpose to get people to want to buy in to what you're advocating for. And that's it.
So I also work in like health service implementation, digital things. And I'm sure I'm going to talk about this because I'm sure you have the successes and those successes and share about like what really led to those successes and how do we build up the connection with health services for those services.
So I suppose one of the places where I've had most success is in congenital heart disease in the UK. And back in 2012, my team, we built a risk model for 30-day deaths after surgery in children. And this kind of came about back in the late 1990s. There was a big scandal when one hospital in England had much higher death rates in babies than others. And there was a whole parliamentary inquiry in it, and they said you have to start monitoring deaths. But obviously it's a very high risk population, and there was no way of adjusting for the risk of the different the conditions that the babies had. And so that's what we did. And so we kind of built the risk model, and then we straight away realized that actually we needed to make it easy for people to use. And so then what we did is we worked with 3 hospitals to build a tool that would let them implement it. And that's where I think it was really key, because we weren't talking to the clinicians, we were talking to the nurses and the data managers who were doing that. And so we did it in Excel, because that's what hospitals had, and that's what they use. I looked at what they had to submit mandatory data to national audit every 3 months. And so we took the format of that data and I made it match so they could just copy and paste directly in. They didn't have to do any filtering. They didn't have to remove columns. I said, right, just put it in and then we will sort it out. I put in a lot of data cleaning checks, because a lot of the data was really messy, like dates, missing fields, if it's random text, does it not have a valid code? And I'd actually ended up helping them to clean their own data, because I would flag it up, I'd put it in the top of a spreadsheet. I'd make it really usable from that point of view. So it wasn't like that, is that research science? No, but that's how you make it useful to people. And then we worked with them to design, okay, well, how do you want to display the results? And then we kind of added that into it. And then, and the NHS actually said every hospital who does heart surgery in kids has to use this software. But the national audit, this is in 2013, the national audit body then got early access to it, because they said, can we just use it? They did. And they used it, and they deleted a lot of records from a single hospital because there was a missing field. And all of the deletions were survivors. And so it looked like the hospital had a really high mortality rate, which they then leaked, and it hit the national press that this hospital had a high death rate, and they shut the hospital. And that was how it was first used. When I woke up, and it was Easter in 2013, like, what the fuck, like, what's happened? And we ended up going to the hospital and helping them correct their data. It turns out it was okay. And then there was a lot of anger, right? People were really angry. So we then did a tour of every hospital in England that used it and explained, firstly, that is not how it was intended to be used, and this is how it could help them, and this is what they needed, and please get in touch if they had any issues. And luckily that worked. People have been using it ever since, and we've just done the latest update this summer. And within 2 days of me releasing the latest version of that software, every hospital is using it, and I haven't had any issues. So in that sense, I think that's been quite good. But the key is to make it useful. And then another one that I did with Great Ormond Street Hospital for Children is I made them an Excel spreadsheet tool, and again, deliberately Excel, for forecasting bed demand. And again, I worked with them and said, okay, what is the format you get things in? How do you want to see the results? What is it, how can we make this really easy to use? And again, they then use that. They're still using it every day without my support for the last 10 years. And I think, again, it's about working with the people on the front line and not the senior people. Like, to me, that's how you often get it into practice. That was quite a long answer. Yes.
So what actually you could.
So I think if I was doing it again, I wouldn't just tell people this is what's happening, right? I would say, here's an idea, this is how it might make things better. And then think about, okay, do we want first names or last names? Do we want to give people a choice? Do we want to include role? How do you want to describe that role? What's the best way of putting that information on there? It's not a sticky note. Right? So, do we actually need to invest a bit of money in making nice surgical caps for people? How do you deal with hygiene control? And actually having that conversation with the team over several weeks, if not months, is I think how you have to do it. And then design with them a way of measuring whether it improves things or not. And then having the option of saying, if it doesn't, we can go back to using just scrub caps. So I think that's how I would do it now.
It's like being wrong with that.
Yeah.
And
But I think also it would have to, you'd have to address the hierarchy issues. I think you would have to have quite difficult conversations with the team about, because this, I don't know how many of you work with surgeons, but they tend to be quite dominant, and recognizing that actually different peoples in the team have different experiences of being in that OR, right? And to help people see that whether they have a name on the hat may not help them, but it might help others. And whether that's a motivating thing for them or not, I don't know. But I think you have to try and address that side of it as well. I mean, I do think there's a lot of psychology involved.
Well, thank you so much.
Right.
We really appreciate you coming here, sharing your time and insights. Yeah, thank you so much.